Hello guys, welcome to the video. Today we're talking about lymphadenopathies, lymphoma, plasma cell dyscrasias, Langerhans cell histiocytosis. So without any further ado, let's get started. So as we can see over here, we have a lot of terminology here, and a lot of them have different meanings behind them, but don't worry, we will get into every single thing. So first of all, what is lymphadenopathy? That means basically any sort of lymph node, any sort of lymph node is more like a kind of like a structure which has a lot of immune cells, and can really helps with producing immune responses. And the lymph node becomes enlarged. So this lymph node over here, it is basically a secondary lymphatic organ, and this has a function of non-specific filtration of macrophages, circulation of B and T cells, and immune response activation. By the way, this is a secondary lymph organ. Other secondary lymph organs are our spleen. It can be maybe our Bayer's patches, and also around our tonsils and our pharynx, lymphatic tissue over there. What are primary lymphatic organs? The B as in bone marrow and T as in thymus. So according to the first letter, they have their cells that they produce or mature. So what is going to be the two types of lymphadenopathy? So there's two types, either painful and painless. So very simple. Painful is any sort of infection or any sort of viral, bacterial, protozoa, any type of that can cause painful lymphadenopathies. So usually seen in lymphadenopathies that are draining a region of acute infection, for example, acute lymphadenitis. So the way we're going to remember this is through a mnemonic called HEAT. So H as in HIV, E as in ABV, A as in group A streptococcus, and T as in toxoplasmosis. All can cause painful lymphadenopathies. Painless lymphadenopathies, I just want you guys to remember painless as in tumors. Any sort of tumor, we're going to talk about this a lot, and chronic inflammation, any sort of metastatic carcinoma coming to your lymph node, or any sort of lymphoma. So I just want to memorize that as painful. So guys, but why do we have pain in the infections but no pain in, for example, tumors or chronic infection? Well, that's because of inflammation. So when you have inflammation, why do we have pain? So when you have painful lymphadenopathies, you usually are gonna be due to acute infections, and for example, acute lymphadenitis. So acute inflammation, we have prostaglandin E2. Prostaglandin E2 kind of sensitizes the nerve endings along with bradykinin, which then leads to, so whenever you have inflammation or due to infection, you may have some sort of inflammation, and that inflammation produces prostaglandin E2 and bradykinin, which kind of sensitizes our nerves, which is going to our brain, and that leads us to experiencing pain in our lymph nodes, in our chest, stomach, wherever. But that's the main end line. More about painful lymphadenopathy. So painful lymphadenopathies are basically hyperplasia of the follicle of the lymph node, and basically we can get hyperplasia in three main areas: the follicle, which is the one I'm showing here, the paracortex, which I'm showing over here, and then we can also get in the sinus, so the medullary area, which contains our histiocytes. So we're talking about, first of all, we're going to be over here talking about our what do you call it, we're going to talk about the follicles. So as we can see over here, there's going to be follicular hyperplasia, there's going to be the B cell region, and it's associated with rheumatoid arthritis and also HIV. So it's going to be showing with two main, autoimmune attack and HIV, and this is going to be occurring in the kind of the outer region, which is kind of the follicular sites, which contains the B cells. The second one is paracortex hyperplasia, which is going to be around the T cell area. This is going to be, for example, infectious mononucleosis from a Epstein-Barr virus. So that's kind of over here. That's where the T cells are located. And yes, we do have another type of painful lymphadenopathy, and that is called the sinus, the inner part, which is going to be the sinus histiocytes in the lymph nodes that are draining a tissue with cancer. So that's going to be kind of in the center part of the histiocytes, and so we're going to get histiocytes, hyperplasia of sinus histiocytes. So guys, it's time for a quiz. Yes. You have a 40-year-old patient, and he's a male patient, and he comes to you with fatigue, fever, sore throat. You take a throat sample, you do a monospot test. In monospot test, we look for anti-heterophil antibodies, which are basically, because they're a horse antibody, so they're heterophil. They're like kind of like a different organism, so heterophil, and it finds out that you're EBV positive. So maybe usually EBV occurs in younger patients. I should have probably mentioned it was a 20-year-old patient, but okay, and it turns positive. So which part would be enlarged? So is it either the follicular, is it either the capsular, is it paracortex, or the medullary sinus? So do you think it's going to be the outer region, which is follicular, which contains our T cells? Do you think it's the inner region, which is going to be our paracortex, which contains our B cells? Or do you think it's going to be the sinus histiocytes, the medullary region, which contains our sinus histiocytes? Or do you think it's going to be the cortex? So guys, for those of y'all who chose paracortex, that is completely correct. Paracortex is the area where we have T cells, so that's where you're going to activate EBV. And how about the follicular? What will follicular activate? Well, it activates two main diseases, rheumatoid arthritis and also HIV, as I showed in the next slide. And how about the histiocytes? Well, that's going to be some sort of well, let's go check histiocytes draining the cancer. So it's a cancer and capsules. I don't have any pathology that I know of, so yeah. So guys, next thing is multiple myeloma plasma cell dyscrasias. So you might be looking dyscrasias and wondering what even is dyscrasias. But dyscrasias is basically any sort of a blood disorder, any sort of blood disorder. And over here we'll be covering three main diseases: multiple myeloma, MGUS, and Waldenström microglobinemia. Don't worry, I have a lot of mnemonics, so it should be very easy. So disorder of the blood and an imbalance of body fluids. So any body fluid could be blood, bile, lymph, phlegm, which is kind of like your thick mucus, the mucus that comes out of your mouth, your respiration, your GI, your respiratory tract it comes out of. So multiple myeloma. So multiple myeloma, if you thought that this is looking at this and thinking that it's a benign tumor, if you think this is benign, well, psych, that's the wrong number, because it's actually it's cancerous, it's malignant, it's a tumorous, it's cancerous. Malignant proliferation of plasma cells in the bone marrow. The most common primary malignancy of the bone, and the most common malignant lesion of the bone. So very common, that's what we take home. And this leads to more amount of interleukin 6. But you might be wondering how to remember interleukin 6. Well, no problem. You can use the hot T-bone steak mnemonic, which I took from the book. I have not referenced it here, but USMLE first aid book, definitely check that out. First aid, it's in, I think, 2021 edition, so check that out over there, full copyrights to them. And so yeah, so the one is we can hot, the 2 is T cells, the 3 is the bone, the 4 is IgE, the 5 is the IgA, and the 6 is going to be the acute phase protein production. So number 6 is going to be the K, which is otherwise known as acute phase. So you're producing acute phase protein, which are proteins from your liver, and also due to that, it can also you're also stimulating plasma cells and immunoglobulin production. The next thing I want to talk about is going to be, yeah guys, we can talk about a little bit about the mnemonic, which is otherwise known as the mnemonic called crabs. So over here it's going to be divided into CRABS, so kind of a bit of a twist from my side because usually it's only crab, but yeah, so it's me called CRABS. So C is going to be starting here for constipation. So what does constipation mean? Basically it's going to be due to the fact that we have a lot of amount of calcemia over here, and because you have a lot of calcemia, remember the calciums are kind of blocking the gate to the muscles. So let's just imagine over here we have a muscle below over here, and this is going to be the depolarization. So if we have a lot of calcium, let's just imagine here, here, and here, and here, then we're not going to get enough sodium going in. So that's going to be the problem. You cannot get enough sodium going in, you won't get the depolarization, and you won't get the contraction. So yeah, neoplasia of the plasma cells activate the rank receptors on the osteoclast, and when you're going to be activating the rank receptors on the osteoclast, what is going to be really happening is that the rank receptors are basically the NF kappa receptors, and they are on the osteoclast, and they kind of lead to bone destruction. They kind of are so we have them over here. I took this from researchgate.com. So we have these rank receptors over here. I believe they are located over here, and these are rank ligand. They go in the osteoclast, and they're kind of activated by these plasma cells. Plasma cells then activate these I believe these osteoblasts. Osteoblasts then go activate the osteoclast, and then this cell over here goes and destroys the bone over here. So it causes these punched out lesions or these osteolytic lesions, and they're located in the vertebra and the skull, and they increase risk of fracture. The next thing is going to be our renal involvement, Rolex formation, RBCs, and risk of infection. So Rolex information is going to be the red blood cells on the blood smear, increase serum protein, decreases the it decreases the charge between the red blood cells. Proteinuria, the free light chain is going to be excreted in the urine as Benz-Jones protein, and they can kind of deposit on your kidney. And when they kind of are going to be depositing on your kidney, guess what's going to happen? It's going to lead to kidney failure. What else do you expect to happen when our monoclonal antibody and plasma cells are not working? So if our plasma cells are not working, we're not making antibodies, immunoglobulins. So when we're not making immunoglobulins, then what's going to happen? We're going to get a risk of infection, and because there's a lack of antigenic diversity, and infection is most common cause of multiple myeloma. What are the clinical features? It's going to be, like I said, there's C, we finished R, now we're on A. A is going to be anemia and amyloid. What's primary AL amyloidosis? It's going to be free light chain circulating in the serum, and they kind of also do deposit in the tissues. Where are these amyloid coming from? Well, these are because the plasma cells are obviously not working anymore. So instead of producing a heavy chain, and then they also produce a light chain, they're only making the light chain. So these light chains over here and this light chain over here. Anemia. Why are we having anemia? So the reason we're having anemia is because the overgrowth of plasma cells in the bone marrow, and this leads to too much crowding and leads to a decreased number of blood cells or forming cells. Now we spoke about C, we spoke about A, we spoke about B, which is the bone marrow involvement. I kind of spoke about it in the previous slide. And then the S. What is S? S is serum proteins are being elevated. So the neoplasmic, the plasma cells, what are they producing? They produce immunoglobulins, IgG, and this leads to a M spike, an M spike on the serum protein electrophoresis, most commonly due to IgG and IgM. So this is what electrophoresis looks like, a normal guy's electrophoresis. This is what the multiple myeloma looks like. So we can see this troll face over here, or a person who has a disease. So your alpha globulin is making your antitrypsin protein, your alpha-2 globulin is making your haptoglobin, your beta globin is making your IgA, IgM, whatever, and then over here your gamma globin is making your IgG, it's making your IgM and your IgA. So when we have a lot of gamma globulin, then we're going to have an increase over this side because we're having an increase in IgG, right? So we're going to have an increase on this side, and also we're having an increase in IgA, so again we're having an increase on this side, and it's going to look like what? M sign, McDonald's. Remember, you have McDonald's with multiple myeloma, M sign. Treatment, you don't need to know treatment for pathology, but I just found some memes on the internet, so I was like, why not? So thalidomide, I don't know if you guys know it, it was rejected for birth defects, and it was given in pregnant women, and they used to get birth defects. But and then thalidomide is approved for multiple myeloma. So it's kind of like it's not allowed in people who are pregnant because it would lead to birth defects, but it is allowed in people who are who have multiple myeloma. So this one over here, one does not simply cure multiple myeloma with high dose myelin and autologous hematopoietic stem cell transplantation. So these are kind of like the myelin and high dose autologous hematopoietic stem cell transplantations are kind of there for giving the stem cell transplantation, because you need autologous stem cell transplantation, and myelin is also a very effective drug for anti-cancer drug along with thalidomide. So I think you need to kind of give a combo of thalidomide, myelin, and autologous hematopoietic stem cell transplantation. Let's talk about Waldenström macroglobulinemia. So this is going to be due to M, which is going to lead to increased production of IgM, and this can lead to peripheral neuropathies and no crab, but it does lead to Krabs. The S does apply here, which is increase in serum proteins. When you have increase in serum proteins, you can imagine your blood is now becoming honey. It's much more thicker. And when you get which is basically for hyperviscosity. So imagine your blood is much more thicker. Then you have hyperviscosity syndrome, and you can learn it through a mnemonic. No need to memorize it. So A as in headache, B as in blurry vision, C as in problems with sight. So therefore you're having retinal hemorrhages, you are not able to see. And then Raynaud phenomena is going to be basically a decreased blood to the fingers. Waldenström macroglobulinemia is going to show bone marrow analysis shows above 10% lymphocytes with intranuclear pseudo-occlusions, including IgM. So you're going to have, let's just say, bone marrow analysis. We have our red blood cells, and then we have these big lymphocytes, and they have IgM inclusions inside them. I forgot to mention in the previous multiple myeloma, I mentioned the clinical features, but I did not mention the clinical diagnosis of multiple myeloma. So how do you diagnose multiple myeloma? Well, diagnosis of multiple myeloma is also, like we spoke about, is going to be with this. We're going to be getting this we're going to be getting, so we're going to get this M spike over here, but also on, we're going to take a bone marrow biopsy, and again, we're going to see plasma cells. The red blood cells will be there, but they're going to be quite small. But a lot of plasma cells, monoclonal plasma cells. And these plasma cells, they have chromatin. They kind of look like a clock. They have chromatin looking like a clock. So intracytoplasmic chromatin, and that's my characteristic features. But no, monoclonal gammopathy of undetermined significance. So this is going to be basically no crab, just the S. So crabs. So we have increase in seroprotein such as IgG. So we have less than 10%. Remember in multiple myeloma, when I drew it over here, we have more than 10%. So maybe like 15% or 20%. But over here it's me less. That's gonna be the main thing over here of monoclonal plasma cells. So that's the main way you differentiate between MGUS and multiple myeloma, because they both are gonna have these M's. They both have McDonald's. But yeah, another to them, MGUS is gonna be elderly, and it does lead to 1 to 2% becomes multiple myeloma. So yeah. Okay, quiz time. So a 61-year-old patient comes in the office because of headache, blurry vision, changes in the color of the hands, no history of alcohol, no history of tobacco, experienced a lot of burning in the tip of his hands. Upon diagnosis, the serum protein electrophoresis, the diagnosis is going to be shown below. So it's going to be shown below. So on electrophoresis, basically his alpha 1, alpha 2, beta, and then this is his gamma. So this is gamma, this is beta, this is alpha 2, alpha 1, and this is his albumin. So this was his electrophoresis. Which of the following is going to be the most likely on bone marrow biopsy? So you guys can pause and think about it. But this is going to be Waldenstrom microglobinemia. So that's going to be there. What do we see on bone marrow biopsy? Like we spoke about, it's going to be red blood cells, but they're going to be these lymphocytes with these IgM inclusions. So we can see, and they're above 10%. So we can see where lymphocytes with these inclusion of IgM. What is 5% with monoclonal plasma cells? What is this? Please let me know. Basically, this is going to be any sort of a not tumor. It's going to be more of a it's going to be the Waldenstrom microglobinemia. It's not going to be multiple myeloma. Waldenstrom microglobinemia is going to be MGUS. It's going to be MGUS with 5% of plasma cells, and this is going to be multiple myeloma. I remember saying the clock phase chromatin. I did mention this intercyclism of IgM. Part number 3 is going to be lymphomas. Don't worry, we only have part 3 and part 4, and part 4 is where it ends. Neoplastic proliferation of lymphoid cells that form a mass may arise in the lymph node or any extranodal tissue. What's that? That is, for example, what can you give me an example? So spleen is one of them. Possibly some sort of lymphoid tissue in our pharynx. So I'll put a P as in pharynx. Perispastis is a good shout. Maybe the liver. I'm not sure if liver has lymphoid tissue, but maybe. So non-Hodgkin can be divided into many things. The ones we're going to be talking about is B and T cells, slightly size, and they're like where they kind of grow. So and obviously we're going to classify them upon another classification is kind of Hodgkin versus non-Hodgkin. So let's classify them upon size. So small B cells will be follicular, mantle, marginal. I know this won't be making any sense right now, but I'm going to get into the details in the next pages. So I want to first of all differentiate what's the difference between a lymphoma and leukemia. Well, I got this from Dr. Najib's video and where he explained this. And he basically said that leukemias are basically like milk. They kind of look like milk. And these are lymphoid or myeloid origins that have wide spread. So they're kind of like milk in the bone marrow. And the tumor cells are usually present in the peripheral blood. Lymphoma is kind of distinct tumor, which arises in the lymph node. It's kind of like butter. It's more like in the lymph node. And they have variable clinical presentations, for example, atypical sites, leukemic presentations. Hodgkin versus non-Hodgkin lymphoma. You can put verses, but over here we're talking about similarities. So they are to a certain degree same. So they can cause B signs and symptoms, low-grade fever, night sweats, weight loss, and painless lymphadenopathies. Hodgkin versus non-Hodgkin. Now here's the real verses. How do you differentiate the two? So Hodgkin lymphoma is going to be not very common, and it's going to be 40%, whereas 60% over here. Hodgkin, like I said, is kind of like Hodgkin is going to be kind of localized to a single group of nodes, and with a contagious spread is going to be the stage. The contagious spread kind of tells you that it doesn't really spread that much, so it has better prognosis. It presents again painless lymphadenopathy, B symptoms, and young adults. So it has bimodal. So either it can be young adults, so people like 20, like my age, and then above 55 years old, so elderly people, and they're more common in males, except for non-sclerosing type. That's common in many in the female gender as well. The main cells we're going to talk about is the next page. EBV is going to be here, but it can also be all non-Hodgkin, so be careful about that. Composition of mass is going to be mainly reactive cells. So for example, inflammatory, fibrosis, so your eosinophils may be there, basophils may be any sort of reactive. Contagious, it rarely goes to the spleen, it rarely goes to the extranodal places, and guides therapy, radiation is the mainstay, and leukemic phase will not occur. It cannot spread into the blood. Non-Hodgkin is 60%. It involves multiple lymph nodes, so it can involve our cervical, our inguinal. It can involve many things. Extranodal involvement, non-contagious spread. Painless lymphadenopathy comes in late adulthood, can occur in children and adults, and also it's going to be there with lymphoid cells associated with autoimmune diseases, viral infection, HIV, EBV, human T lymphotrophic virus, and it can also lead to lymphoid cells. It can be diffuse, often extranodal, and it has limited importance, and leukemic stage can occur. Okay, Hodgkin lymphoma. What's the deal with Hodgkin lymphoma? Hodgkin lymphoma is a Reed-Sternberg cell, and these are going to be basically an owl. They're going to be binucleated, bilobed, and they have these owl. And the Reed-Sternberg cells can either be CD15 and CD13. Have I mentioned the mnemonic here? Okay, there's a mnemonic to learn this. Oh, okay, yeah. So the CD15 and CD30, I got this from a book called, as I mentioned, First Aid USMLE 2021. I'm gonna link it back, and I'm gonna keep the reference to it in the in the reference page, so that you guys can kind of go out there and check it out for yourselves. So basically over here we can see there's two nucleuses bilobe, so 2 times 15 equals to 30. So that's gonna help you memorize the CD markers if ever needed. Okay, lymphocytes. Okay, yeah. So over here, lymphocyte depleted is gonna be the worst prognosis. Poor people have this is again from First Aid USMLE. As you guys can see, First Aid USMLE 2021 edition is the book which I've shamelessly taken too many mnemonics from. Check it out. Worst prognosis, worst bank account, senior immunocompromised. Sclerosis is very common, the most common type. It's kind of your lymph node is going to be sclerosed with all the fibrosis. Eosinophils, eosinophilia, seen in immunodeficient. Lymphocyte rich is going to be best prognosis. Rich people have the best bank accounts. So yeah, non-Hodgkin lymphoma. What's the deal over here? Non-Hodgkin lymphoma. So we're gonna have to do it like this. Non-Hodgkin lymphoma, we have secondary lymph follicle and we have a primary follicle. So primary follicles, we can kind of just forget about it, and in the secondary follicles, let's get into it. So over here we have a marginal zone, a mantle zone, and then the whole thing itself is always got follicular. So when we have a marginal zone lymphoma, the tumor will be here. When we have a mantle zone lymphoma, the tumor will be here, and then when we have a follicular tumor, it might be over here. So follicular lymphomas are going to be these small B cells that form follicles like nodules. They cause painless lymphadenopathies, and the translocation, it kind of occurs from the T1418, and I'm going to give a mnemonic for that next page. So basically on the BCL on the chromosome number 18, what's the deal with that? So the BCL chromosome, the BCL gene on the chromosome number 18 is basically going to be responsible for the heavy chain locus on the chromosome number 14. And chromosome number 14 is key because and basically BCL inhibits apoptosis, but over here in chromosome 14 we have a overexpression of heavy chain IgG. So we're kind of overexpression. So when you put a thing that inhibits, when you kind of swap it to this overexpression area, it kind of defeats the purpose, and it kind of overexpresses it, and therefore the cell can never die and leads to cancer. We can give chemo, we can rituximab. Please stick it in your in our minds because they cause anti-CD20 antibodies and complications, diffuse large B-cell lymphoma. Mnemonic. So let's talk about this. 4 translocation between 4 and 14. So 14 should help you remember. I should the 14 over here should remember follicular, and then because there's 14, add 4 to 14 equals to 18. So that's what help you remember it. So from follicular, remember 4, and then from 4, remember 14, and then add 4 to 14. That will give you 18. So that will help you remember these two translocations over here between 14 and 18. Mantle cell lymphoma. Mantle cell lymphoma is a small size B cell anti-20 that expands the mantle zone of the lymph node. It occurs in painless lymphadenopathy. Okay, translocation. Let's talk about this. So basically, 11. 11 is means cyclic D1 is going to be chromosome 11. It is translate again to 14. 14 is going to be the hyper area. 14 is kind of like the hyper area. And whenever you put a cycling D1, is the kind of the it's kind of like the regulator that allows the cell to go from the G1 phase to S phase, to kind of regulates that thing. And overexpression would then lead to neoplastic proliferation because we're overexpressing it. This one, I shamelessly took this from this person called Baron Rocks. He has a very good mnemonic for this. So basically, he says that the translocation from mantle cell lymphoma, it has to be T bracket comma. So it has to be 4 numbers. So we put 1, we put 2 or 1 again, we put 1 again, and then we put 4. So that's kind of the translocation. It's 4 numbers. That's all you have to remember. Marginal cell lymphoma, it's going to be again small, and this is the main thing. It's associated with hematoma arthritis, arthritis with hemothyroidism, Sjögren's syndrome, dry mouth and dry eyes, and H. pylori. The marginal zone of the lymph node is made out of these B cells, so you're obviously having inflammation in those. And even if you get therapy for H. pylori, you may get regression. It may occur again. Burkitt lymphoma, again, this is intermediate. And EBV, which I have a question for you guys. Where else does EBV occur? Which other tumor? The answer is Hodgkin. It can occur in Hodgkin lymphoma. And the main thing learned occurs in the jaw and occurs in children. Everything else I mentioned previously was in adults. This one's in children. And another way to help remember this is with Mickey Mouse. How? So Burkitt lymphoma, it's gonna remember it like this. When you see Burkitt lymphoma, think about this like a Burkitt as in boy. When you think about boys like to watch Mickey Mouse. So when you draw Mickey Mouse on your paper, draw Mickey Mouse's ear. When you draw Mickey Mouse's ear, we're going to basically see the number 8. So 8, and from the other ones, we know 14 is always there. Actually, in most cases, I think in every case, 14 is there. And then we're going to get this, and Mick over here will remind you, see Mick, look at Mick. So just drawing Mickey Mouse's ear, we can see Mick, and that can give it high motoric index, meaning it replicates a lot, and starry sky should be easy to remember because Mickey Mouse is looking at the sky, right? Diffuse large B-cell lymphoma is late adulthood, extranodal mass, very aggressive, most common cause, and it can grow in sheets. Now this one is the only T-cell lymphoma. Remember previously as I showed, everything was B-cell. B-cell. Everything was B-cell. This is the only one I'm going to be talking about is just T-cells. Neuroplastic proliferation of T-cells leads to skin plaques and patches. So on the person's hand or on his back, like he might come with his hand, he may have these packs or plaques. And on when you take a histology, what are you going to see? So in this cell, we're going to see these cribriform nuclei, which basically means any sort of nuclei with indentations, with kind of separations. And then we also see these on a skin biopsy, we can see these Potter microabscesses. Here's going to be the question. So here a woman comes to history of weight loss, weight gain, cold intolerance, swelling around the throat, diarrhea, or should we notice hypercholesteremia, low glucose, ECG shows bradycardia. What type of lymphoma's translocation is most likely associated with? So first of all, what do you think she has? Well, she has hypothyroidism. She probably has Hashimoto thyroiditis. Which one is Hashimoto thyroiditis associated with? Pause the video if you don't know. And you will have she will have marginal zone. So marginal zone lymphoma. And so it's not associated with any sort of translocation. So now what is this? Is mantle cell. This is your Mickey Mouse, so Burkitt, and this is going to be your follicular as in 14. Langerhans cells. Langerhans cells is going to be basically mnemonic, because you can't understand it if you memorize it. So They're dendritic cells, and they're found in the skin. They come from the bone marrow, so our bone, maybe our femur. If this is a decent drawing of our femur, it comes from the monocytes, and they are kind of like antigen presenters. They kind of present always, so they always present to your big boy T cell. So this is going to be maybe a Langerhans cell, but this presenter is presenting to your big boy T cell over here, which will do the immune response. So what is the deal with Langerhans cell? Langerhans cell is going to be a neoplastic proliferation. So Langerhans was a scientist called Paul Langerhans. I think he was from America. I need to double check where he's from. And he was a scientist who liked to play tennis, and he used to discover cells. So from that, on histology, we'll see tennis rackets or Barbic granules on electron microscopy, and the cells will have CD1 and S on immunohistochemistry. C cells, CD1 and S as S100. So please memorize it. Now, one type of Langerhans histiocytosis is going to be otherwise known as the Letter-Suis disease. Letter as in lethal, and it's malignant, rapidly fatal. So malignant Langerhans cells proliferation, and then the S will help remember it's a small kid. It's a skin rash, so it's gonna be less than 2 years, and also cystic skeletal defects. So cystic skeletal defects. Mnemonic. Okay, hand-scular Christian disease. We can just remember this H as in horrible, and that will lead to malignant proliferation of Langerhans cells, just like the previous one. But the main thing is you can just remember the sled. He kind of sled to his death. This child kind of sled to his death. That would be a scalp rash, a lytic skull lesions, diabetes insipidus, and exophthalmos in the child. This is the only one in the adults. It's going to be this. It's not going to be the same because it's the only one in adults. It's not the same. So it's going to be benign proliferation because this is in adults. It's pathological fracture. Skin is not involved, and we're going to see mixed inflammatory and eosinophils. So eosinophils, mixed inflammatory, adolescents, that means in adults, and skin is not involved. Quiz time. An 18-year-old boy comes to the rash, cystic skeletal defects on X-ray. He is admitted to ICU with a blood pressure of 80 to 50. Pulse is low, respiratory low. What is the likely diagnosis? Pause if you don't know. I'll move on. Letter-Suis disease. Remember, we said L as in lethal. That explains all these: decreased blood pressure, decreased pulse, decreased respiratory rate, and the S as in small boy. So 18-year-old boy. Cystic skeletal defects and rash. Eosinophils, we said it was same, so no skin involvement. Automatically, this guy's the same. He is a boy, so he's out over there. Skin is going to be out over here. A is going to be I know the E is eosinophils, and M is going to be mixed inflammatory cells, and then A is going to be A is going to be adolescent. So yeah, he's an adolescent. And then hand-skewer Christian's disease. Hand-skewer Christian disease is going to be sled. He sled to his death. It's going to be malignant. So we're going to have exophthalmos. The patient doesn't have that. Diabetes, the patient doesn't have that. He's going to have, what is SNLE? It's in scalp rash. He doesn't have a scalp rash. And lytic skull defect. He has cystic skull defects. So guys, thank you for watching this video. References are many. I use other references. I mentioned them previously in the presentation. Copyrights to Baron Rocks, I copied his mnemonic, his website, check him out. Pathoma, I use a lot of Pathoma. I definitely recommend using Pathoma. First Aid USMLE 2022 has loads of mnemonics recommended. Online Medic. Online Medic is more for internal medicine, so don't use it now. Use it when you're 5th year. Hope you guys enjoy this video, and thank you for watching, and I hope you guys found this useful. So, for those of you guys kind of stuck for the end credit scenes, here is your post credit scene. Here is your mnemonic page. Painful lymphadenopathies can be remembered with heat. Multiple myeloma can be remembered from the Krabs mnemonic. Wellington mnemonic can be remembered from ABCD. Follicular transformer can just remember by remembering 14. Mantle cell lymphoma can be remembered by 14. BaronRocks.com, I got the mnemonic from there. Also, this one I got from Baron Rocks, Mickey Mouse one. It's going to be the Berkeley lymphoma, just remember Mickey Mouse. The eosinophil, remember same, skin novum, adolescents, mixed and eosinophils. Hand-screwed Christian disease, remember he sled to his death, so scalp rash, lytic regions, eosinophils, and diabetes insipidus, and Letter-Suis disease. So that's lethal and skeletal skin rash. So this page is for the OGs, the people who stuck to the end, who watched the whole video. And here's your reward, post-credit scene, kind of like a Marvel video, a movie. And I hope you guys found this useful. And all the best with the study. Thank you for watching.